So we waive the quorum. Now I need a motion to accept the minutes from our last meeting. Okay, I have a motion. Have a second. All in favor, please say aye. Aye. Opposed, nay. Okay, first order of business, and I think I'm right on, is we have a presentation on fentanyl and the impact on the workers' compensation market. And it's Phil Walls, who is the Chief Clinical Officer at My Matrix. Am I right, Phil? So go ahead,
That's
Phil.
right.
You have the
Okay. Thank you very much. If I could ask for my set of slides to be brought up on the screen. So while we're waiting on that, by way of introduction, I am a pharmacist. I've been a pharmacist for the past 45 years. While I was in school, I started giving talks to church groups, PTA groups on drugs of abuse. So that means I've been speaking on subjects like this for almost 50 years now. Makes me feel really old. Now, back in the 70s when I was talking on this, I certainly will. Is that better? Good. So back in the 70s, one of the primary drugs that I was speaking on, of course, was heroin. That was when our veterans were returning from Vietnam, and unfortunately, a number of them had become addicted to heroin. Today, what I want you to think about as I go through this presentation is that the primary cause of death today with a heroin overdose is fentanyl, not heroin. So keep that in mind as we go forward. I'll help explain how that's the case. And we're going to talk about fentanyl and the fact that this is a prescription medication. Unlike heroin, which is an illegal substance, it's a Schedule I controlled substance, fentanyl is a legal prescription drug. It's a Schedule II. And yet it has made this journey from being a legal prescription drug to an illegal street drug. So how did that happen? Give a little bit of background on that. I'm going to start off with some definitions, talking about opioids and opiates and drugs like fentanyl, do a brief history, talk about an individual named George Marquardt, a name you may or may not be familiar with. A term that if you don't know today, you will become familiar with. There's something known as IMFs. We'll talk about potency of these drugs, overdoses, and then special considerations for first responders. And this is when we'll really get into workers' compensation, and then hopefully we'll have time for some questions and answers. So opioids. Opioids is a broad term that basically applies to all of these painkillers that we're going to be talking about today. Specifically, though, opioids are the ones that came from the opium poppy. So these are a natural product. You know, we hear all the time today about cannabis, that cannabis is a natural product. Well, that's true of many drugs, morphine and codeine in particular. Both of these are derived directly from the poppy plant. Now, pharmaceutical science, we take drugs that occur naturally and we alter them. And usually that's to do one of two things, make them safer or to make them more potent. And so in the case of opioids, when we convert an opioid into something that's now man-made, a semi-synthetic opioid, that is referred to as an opiate. This includes drugs like hydrocodone, which we see so often in workers' compensation, hydrocodone, oxycodone, even heroin. So heroin was created shortly after morphine was isolated from the poppy through a process known as acetylation. Probably all familiar with vinegar and what vinegar smells like. Well, that's acetic acid. So acetylation is basically treating these drugs with acetic acid. It changes them. In the case of morphine, it created diacetylmorphine or diamorph, which was the brand name became heroin. Heroin was a drug created by a company known as Bayer. Bayer is, of course, still around today. At the time they did this, they were not Bayer Pharmaceuticals. They were the Bayer carpet dyeing company. To make carpet dyes more vibrant, they would use this acetylation process. Well, one year there was a shortage of raw materials to produce carpet, so they had to look for something else to do. and they tried this process on morphine and produced heroin. Shortly after, they produced aspirin. So it's the same Bayer pharmaceutical company we know today. And then we have synthetic opioids, which is unique in that these opioids, we do not have to start with the opium poppy, okay? So that means that they're a lot easier to produce. The most common ones that we know of are methadone and fentanyl. So where did fentanyl come from? It's an extremely potent drug. Morphine is quite strong. All the other derivatives are quite strong. So why did we need this drug known as fentanyl? Well, a Belgian physician, first synthesized fentanyl in 1960. And what he found in producing this drug was that it had all of the good benefits of the opioids, and then it had two unique factors. One, it's extremely rapid acting and has a short duration of action. So for anesthesia, these are very good qualities. You want to give the patient something that is going to, put them under for a short period of time and then wear off quickly so they don't have that delayed recovery period. So from that perspective, fentanyl was a very good drug. It also has fewer side effects than the other opioids, a lot less nausea and vomiting for most patients. So his intention was to create a drug that was going to be an improvement over the existing opioid, and he did that. Then the drug found further use when they created duragesic patches. So they took a drug that was extremely rapid acting and short acting and turned it into a long acting version. Why did they do that? Well, they wanted to go for those characteristics that produce less nausea and vomiting, so the fewer side effects. So by putting in a patch that is slowly released, they were able to create an opiate that had these characteristics and yet would stay in a person's system for a long period of time. Now, a couple of comments about the duragesic patch. It's effective for 72 hours. At the end of 72 hours, there is still a significant amount of fentanyl left in that patch, enough to kill a child or a pet. So disposal of these patches, people have to be very careful, and they have to be instructed. One, the sticky sides should be folded together, and then it should be placed in something that where it's not going to be, retrievable. Throwing it out in the garbage is not a good idea. The FDA years ago told communities, quit flushing drugs down the toilet because we were starting to see significant quantities of drugs in public water supplies. And it's not a good thing. Then they had to sort of backpedal, and they came back and they said, okay, there are some drugs that are so dangerous that actually we want you to flush them down the toilet. The opioids, all of them, including fentanyl, made that list. They are so dangerous, they have to be gotten rid of, and have to be gotten rid of in a way that no one can find them. So then pharmaceutical companies, as they always do, continue to find new uses for an old drug. And that's when in the early 2000s they came out with something known as the Actique lollipop. It was a fentanyl lollipop. Now, why on earth would we put something as potent as fentanyl in a lollipop? Well, it was designed, again, for a good purpose. Most drugs are designed for good purposes. It's just that then their use is changed and used in ways that it shouldn't be. With fentanyl, the idea here was end-of-stage cancer, end-of-life cancer patients. So individual, they know they have a short time to live. They do not want to be in hospice. They do not want to be in the hospital. They want to be at home. And yet caregivers, most caregivers, are not trained in how to take care of these patients, especially when it comes to injecting something like morphine. So the idea with fentanyl is that the fastest way to get a drug into the human body, other than an injection, is absorption through the oral mucosa. So by the patient sucking on a lollipop, the fentanyl will go to work very quickly, and so it made sense to do it this way, but only for that use. Unfortunately, we saw fentanyl being used, the Actique lollipop, in workers' compensation. It was never intended for low back pain. It was an off-label use of a drug that was not a good off-label use. So being purely synthetic, what that means is that this drug can be made by one person in a lab or in their parents' basement. If any of you have watched the series Breaking Bad, of course, is about production of methamphetamine. Apply that same thought to fentanyl. It is just that easy. A young man named George Morquat, he was a high school dropout, a self-described genius, did this. He went into his parents' basement and started producing fentanyl. Now, the implications of this may not seem that striking, but heroin is hard to produce. There's a huge market for it. So in the black market, there's a lot of money that is made on the sale and the transport of heroin. But you have to have the opium poppy in order to produce heroin. Fentanyl, being entirely synthetic, does not have that restriction. It is very easy to produce. So if we stop thinking for a moment about the dangers of this drug, and we stop thinking about the illegality of this black market, and think as business people, which one would you want to start with? The heroin, the opium poppy, or a few chemicals that can be obtained fairly easily? Well, George's idea was, well, if I can produce this, I can take over the opioid market, and that's exactly what he did. He ended up serving time. There were a number of deaths that were tied directly to him. I think the number of deaths today tied to fentanyl are almost uncountable. It's tragic. But because it's so easy to produce, and I started off saying that the majority of heroin overdoses are caused by fentanyl, because fentanyl is replacing heroin on the streets. It is so much easier to produce. Now, a lot of it is coming in from China. A lot of it's coming in from overseas, but a lot of it is also produced in this country. Now, in just a little while, I'm going to show you a map on how this is affecting first responders. You're going to see a predominance on the East Coast. This is because within the United States, the type of heroin that has always been on the East Coast is very different from the type of heroin that is in the western part of the United States. The western half of the United States deals with what is referred to as black tar heroin, and it's exactly that. It is a black tarry substance. The heroin on the East Coast is pure. It's a white powder. It's a lot easier to substitute fentanyl, which is also a white powder, for heroin on the East Coast than it is the West Coast. So that's why there's been this shift. Unfortunately, though, it is spreading throughout the United States, so it's no longer, it definitely is not restricted to the East Coast. Now, IMFs. There are 42 illicitly manufactured fentanyl analogs on the market. So what's an analog? It's just a slight variation in that original structure to make it a little bit different. The one that you might read about right now from the CDC is known as parafluorofentanyl. It's not better, it's not stronger, it's just different. Now, parafluorofentanyl has already been identified by the DEA and made a Schedule I controlled substance. The problem with IMFs and many chemicals like this is these black market chemists are able to come up with things before the DEA can actually declare them illegal because they don't know they exist yet. So that's a challenge in and of itself. Now, fentanyl itself is 50 times more potent than heroin and 100 times more potent than morphine. There's actually another legal form of fentanyl in the market known as carfentanil. Carfentanil, Schedule II controlled substance, known as an elephant tranquilizer, because that's its primary use in veterinary medicine. It is 100 times more potent than fentanyl. Now, if I'm doing the math correctly, that means it's 10,000 times more potent than morphine. When carfentanil hit the streets, because it has the overdose deaths rose dramatically because of this potency. It almost cannot be cut enough to get it down to a safe level to use in place of heroin. So that's a challenge. Now, overdose deaths related to opioids. Most of my talks, when I talk to a workers' compensation market, I'm talking about prescription opioids. And it's been frustrating over the last few years because we've actually seen a decline, a significant decline, in the use of prescription opioids. But we're seeing an increase in opioid overdose deaths. That's because of the increase in the use of illicit opioids. Now, I don't know this for a fact, so I'm going to go out on a limb here, and this is Phil Wall's opinion. We went through a period of time, not just workers' compensation, but this country, where many, many people were receiving opioids inappropriately. We know that many of those patients became addicted to those prescription opioids. Then we launched some very good campaigns to educate prescribers, pharmacists, nurses, everyone involved in the care of patients, that we should use fewer opioids. And we've done that. But we did it without thinking about the people that were already addicted to prescription opioids. So sadly, in my opinion, a lot of people that were addicted to prescription opioids turned to street opioids when their supply was cut off. And the result, we're seeing a significant number of people that are dying from opioid overdoses. 2013 is where we started to see the switch from heroin to these synthetic opioids, primarily fentanyl. And still a problem today. Now, in the interest of time, I'm going to skip on to talking, well, first let's talk just for a moment about signs and symptoms of an overdose. The person is going to be unresponsive. Their lips and their nails are going to appear blue because they can't breathe. A situation like this, first thing, call 911. If you have access to naloxone, administer it. Do not worry about whether or not you know for sure that this person has an opioid overdose, because naloxone, brand name Narcan, all it does is block the effect of opioids. In many ways, it's tragic that it's a prescription-only drug in most states, because prescription drugs are made prescription-only because of safety concerns. Well, naloxone, if it's administered to someone who is not in an opioid overdose, basically it's not going to do anything. So there's no concern over the safety for these individuals. Actually, there's more concern over safety if the person is indeed in an opioid overdose. Why? Because when you give them naloxone, it immediately blocks all their opioid receptors and basically takes them out of an opioid overdose and puts them right into opioid withdrawal. They come out of this almost immediately, for most opioids, not fentanyl, and when they come out of this overdose, many times they're combative. These patients have been known to actually hurt the person that saved their life, because they come out, they're agitated, they're fighting, they've gone straight into withdrawal, which is not a good situation. So that's why I'm saying, first thing anyone should do is call 911. That, even if you have naloxone and you can save their life, you still need that support as soon as you administer that naloxone. So important takeaway from this. Now, with first responders, so when are they going to possibly encounter fentanyl? Well, pretty much anytime. A traffic stop, an overdose call, pretty much anything that a first responder is called to do. Now, how can they be exposed to it? Well, skin contact, inhalation, ingestion, contact with mucous membranes such eyes, nose, etc., or an accidental needle stick. There has been a significant debate about the first one, skin contact, and whether or not fentanyl can actually be absorbed through the skin. Forget the debate. It doesn't matter. First responders are being exposed to fentanyl, and if they're exposed to enough of it, it can kill them. Whether it's absorbed through the skin, that debate can go on for years. Quite frankly, I don't care. More than likely what's happening, yes, maybe they were exposed to their skin, but if there's enough of it that they're exposed in that way, they probably also inhaled some of it. And it is so potent. That's all it takes. There was a very famous case a few years back about an officer who brushed off a white powder on a colleague's jacket, and he went into an overdose situation because of that. That's where most of this debate started. I think by brushing it, that was all it took to aerosolize a few of those particles, the powder, and he inhaled it, more than likely. When this occurs, they're going to need access to naloxone. Most states have taken really good steps towards making naloxone more available, making it more readily available. Before I retire, if I had one wish, it would be, let's make naloxone over the counter. It's a safe drug. Remember what I said. If you give it to someone that's not an opioid overdose, it's not going to really do anything. Is there a chance of an allergic reaction? Yes, there's a chance of an allergic reaction to any drug on the market, over the counter or prescription. So I don't think that's a reason not to make it over the counter. We need more available access. An argument I hear about that is, well, you know, if people have access to naloxone, it might cause risky behavior when it comes to opioids. We already have risky behavior when it comes to opioids. Making naloxone more available, I don't think, in my opinion again, is going to necessarily lead to more risky behavior than what we're already seeing. Now, this is a map. It's a few years old, 2015, that shows the incidence of fentanyl encounters. And as I said, you can see a predominance more towards the east part of the country, but over time that is changing, unfortunately. Now, in addition to access to naloxone, our first responders also need access to personal protective equipment, masks, gloves, things of this nature. So any municipality should be providing this to anyone that's involved. Now, there are kits on the market that a first responder can use to test a substance to see if it's fentanyl or not. Don't spend your money on these kits. Train our first responders that if there is a substance of an unknown origin, assume that it's fentanyl. Just taking the time to test it, one, that alone is going to expose these first responders to the possibility of fentanyl. So don't go through that process. Assume it's fentanyl until we can find out later once it's sent off to a lab. Start with the personal protective equipment. If someone is exposed to it, make sure they have access to naloxone. Now, with naloxone, the overdose is heroin, morphine, the prescription opioids that we're familiar with, a shot of naloxone, or even a nasal spray is going to bring that person out of an overdose. Fentanyl and the IMFs, the illicitly manufactured fentanyl analogs, are so potent that it's probably going to take repeat injections of naloxone in order to bring them out of an overdose. So having one kit available or one vial may not be enough. They need to have access to quite a few because fentanyl is just that potent, just that powerful. After, whatever the incident may be that a first respondent has gone to, anything that's potentially exposed needs to be handled very, very carefully. It needs to be marked as fentanyl contaminated or possibly fentanyl contaminated until we know otherwise. Vital that nobody else gets exposed through that. Now, I've got a few resources here, but you know, if you Google fentanyl, you're going to find a lot of information on it. A few sites do better jobs than others. The CDC in particular has a lot of very good information on fentanyl, naloxone, opioids in general. So I would encourage you to start with that. And then there's some others on here. When I leave today, Will, I'm going to leave you some of my business cards. If anyone has questions, please do not hesitate to reach out to me, call me, email me, whatever. And Will, I'm not sure what the procedure is today. Are we going to questions and answers now?
So, Phil, because
yes, sir.
We each have different subjects, we'll go ahead. I'm going to put it out. But thank you for your presentation. Are there any
Thank
questions from the committee? We'll go ahead.
First of all, I can't, and we met on the phone, I'm Tom Considine, so great to see it. That was just unbelievable, so thank you so much. On the testing, I totally understand the rationale on the first responders, but I don't know if it was Nightline or 60 Minutes or something was advocating the testing, oddly enough, for use at raves and so forth. so that if kids are thinking they're going to use ecstasy, they should use the testing on ecstasy to make sure it's not laced with fentanyl. Do you have any views on that?
Yes, very good point. And, my thoughts today were to focus on workers' compensation, which sort of led me to the first responders. But you're absolutely right. Fentanyl is so cheap and easy to produce that it is showing up in all sorts of different things. Not only, and I hate the phrase, but recreational drugs, but it's even showing up in things that you would not even think would be related to a drug. So in those instances, absolutely, you're right. Test just to know.
Thank you. Ma'am, you have a question?
Yeah, sorry. I'm State Representative Ray Maples online. We've had 4 overdoses in the last 3 weeks. Is there legislation that we can work on that can reduce access to the fentanyl, the catfenol?
Carfentanil?
Or to any of the other ingredients that are going into these items that they're trying to cut this heroin with?
So good question. If everyone didn't hear it, basically what can be done about the sources of the chemicals used to make fentanyl and what can be done to reduce access. Fentanyl is unique in that we're not seeing prescription drug diversion the way that we saw with OxyContin and some of the others. In other words, we're not taking prescription drugs and putting those on the street. We have chemists, and to use that comparison again to Breaking Bad, it is just like that TV series where an individual, once they can get the chemicals, can then produce fentanyl through a fairly easy process. There should be restriction to the purchase of chemicals. I'm a pharmacist, certainly not an attorney. I don't know what type restrictions exist today. I'm sure there would be barriers because many of these chemicals are used for many different processes. So by trying to ratchet down on them to keep them from being turned into fentanyl, we're probably going to upset some other industry that's using them for a perfectly, legal reason. So I don't know about that. The biggest thing is, the DEA, they have a tough job. That's another good website. I mentioned the CDC. The DEA also has an excellent website. Their job is almost insurmountable. So anything that we can do, in my opinion, to fund them and give them more access to resources, the better. So,
Thank you. Last
thank you.
question, Representative Ferguson.
Yeah, thank you, Mr. Chairman. I just want to make sure I understand clearly. You're saying rather than turn your opioid prescriptions into the sheriff's department or take them to Walmart, Walmart has that Dispose RX
Yes.
system that mushes them or whatever. You're saying put them down the toilet instead?
Well, I'm glad you brought that up. So the DEA has created something known as the DEA Take Back Day. You mentioned Walmart, a number of different pharmacies participate in that. Until the DEA did that, it was actually illegal for a pharmacist to take back a controlled substance. We legally cannot do that because there's no paper trail there. When the DEA created the Take Back Day, that is the best and safest disposal method. I'm so glad you brought that up. Short of that, if it's not possible, the FDA says, okay, if there's no alternative, then flush it down the toilet.
Thank you.
But good comment.
I do have one quick question.
Quick question. My state, New Hampshire, is one of the most afflicted, has been for the last 5 or 6 years. Is the production predominantly coming from out of the country, or is that anecdotal that I hear?
I think, and this is not based on fact right now, the last time I looked, China was the primary source. Now, that has changed. There was a period of time where China did not even treat fentanyl as a controlled substance the way that we do in the States. That may have changed, but I would be surprised if they're not still a predominant supplier. Thank you.
Appreciate your words, and I think it.
Thank you.
Like them. Thank you very much. Next person on the agenda is our two people in the discussion on Louisiana's workers' compensation system. First one is Christina Wall, President and CEO of the Louisiana Workers' Compensation Corporation. It's all yours.
Good afternoon. I am Kristen Wall, President and CEO of LWCC, Louisiana Workers' Compensation Corporation. First of all, I wanted to tell you I'm really honored to be here again. I was asked several years ago to come before this group, and Will sent me an email late one night and said, I don't know if you remember me, but would you be interested in coming back? And I said, well, of course I remember you. And I said, yes. And I don't do a lot of speaking to groups, but I really enjoyed it. But I also really appreciate and understand what all of you do. You are setting the policies for your state. We are following all of the policies that you set. Workers' compensation is done differently in every single state. So the chance we get to learn from one another, because there are great things that are being done in every state, and then sometimes there are things that we should be learning from one another. So again, I just wanted to say thank you for inviting me, and thank you, Will. I really am very happy to be back. So I thought I'd take you through like a 2-minute evolution of comp, tell you about Louisiana, tell you about how LWCC was created by our legislature and why, and then the things that we were worried about. And then I'll also tell you about how things have turned out 30 years later. So I just made my 30th year with the company back in October. Never expected that, but you can kind of judge how things went, and so we'll carry on. So again, if you think back to workers' comp came about in the early 1920s, 30s, Industrial Revolution, and people started creating these workers' comp funds. And so that was kind of the first generation that came about. And they really were trying to support the competitive economy, because back then, workers, if they got hurt, they sort of moved on to the next one, right? And that's, A, that's not right, and B, that it doesn't work that way. But state funds came in and they said, we've got to do something, we got to make workplaces safer. So I was listening to Phil talk, and I was thinking about how that's changed just over the 30 years that I've been doing this. Now, safe workplaces involve things like what are first responders being exposed to. We underwrite a lot of municipalities, fire districts, first responders of all kind. So safety now, and what we're supposed to do now, we do that in addition to falls from heights, slips and falls, and things of that nature. So it really has evolved. Fair access to insurance. That's the worst case, is when you can't get insurance and there's nobody to take care of an injured worker, because that is why we're here. That's why we're all here. Operate on a self-sufficient basis, hopefully, and this relentless focus on the injured worker. And I have seen that. I've seen that in all the state funds. I'm a big part of the national organization that we have, and that's what we all have in common, is that we understand that that's the most important thing that we do. And again, that's evolved. To Phil's point, now we have people who are addicted to opioids. Simply cutting them off, it might not be the right thing to do, right? We've got to make sure we do that those types of things very, very carefully, or actually potentially greater harm. Common features, self-supporting, pay dividends. Some people are paying dividends across the country. Some are organized like mutual insurance companies. Some are more state agency driven, subject to regulatory requirements, and then operate in both residual and competitive markets. So I will tell you that there was a big crisis in the 80s and 90s, and it hit a lot of state funds. It hit a lot of states, rather. I can give you some particular insights into Louisiana. Maine was also really in crisis. But there was this instability crisis. The states that had state funds tended to weather it better because they had this mechanism. They were providing this insurance. They were very focused on safety and injured workers. But a lot of states had what we called assigned risk pools, and I'm sure a lot of you have been around long enough to know about that. But we had one in Louisiana, and it really wasn't working very well. That's when all the other companies, all the other insurance companies across the country sort of put in money to fund how it's going to run, how that insurance company, or how insurance is going to be delivered. It kind of comes down to no one is really accountable, and that's what happened. Rates were increasing all across the country. Coverage was becoming unaffordable. And then there was this new self-insured market that started popping up in the 90s. And the economy really did suffer. So again, my friend in Maine here, he was a former
He was a former president there, and he said, you know, if you've seen one state fund, you've seen one state fund, meaning that we're all different. But we do have a variety of characteristics. We're created by our legislatures. Many of us operate as the insurer of last resort. There are still, insurance companies in general terms don't want to provide insurance to a business that pays them, say, less than $1,000 or $2,000 or $3,000. It's a commercial product, and you have to deliver it as a commercial product, but it comes at a steep price. So in general, there's not always an available market for the smaller ones. And then also, there's not always an available market for those who have very high hazards. Some of the state funds are writing other lines in other states. Some have subsidiaries. A few are monopolistic. I know some of you are from monopolistic areas as well. Louisiana in 1991. So this was a state of play in 91. Rates had increased by over 260%. That's a lot. Employers were leaving because workers' compensation was becoming one of their largest budget items. So they were actually leaving the state. So you can create an economy where, if you don't design it right, where it's not attractive to stay. 90% of our employers were in the assigned risk pool back then. And most insurers began leaving to avoid all of these heavy assessments. So we really were left in a crisis. We didn't have carriers in to operate. So LWCC was created. Most people thought it was the dumbest thing ever to create this company with absolutely no money. And most people thought it was going to fail. I'll let you know how that actually worked out. But it was there to provide workers' comp to Louisiana's employers. We began issuing the policies in 92. I was there. I remember it. And we were set up happily by our legislature. They did a really great job as a private company, a domestic company, and a nonprofit mutual insurance company. Put all of the right fundamental pieces in place, not a state agency. Our trade-off, if you will, if it's a trade-off, but we write all business, good, bad, small, you know, everything. We write everything, but we get to price it. We get to have the freedom of rate. Now, rates have to be actuarially sound, and there's an awful lot that goes into that. So LWCC, kind of looking back over the eras, if you will, that we had, I mentioned that people didn't think we would survive. We did. Those were our survival years. And then as we sort of began to come out of those, we said, we really need to learn how to do this well if we want to keep doing this. So we're really in striving mode. Let's get better and better. Let's really understand the intent behind the legislation, and let's really live in our own. Then we moved into our thriving years. Things were good. Things were getting better. And more recently, we realized that we really need to have pride in our state, pride in the associations that we have with one another, and pride in our systems. And so we've been very much involved in that as well. So if you look at Louisiana, LWCC in particular, we say we're a specialist, meaning that this is all we do. We only write workers' comp. We're private mutual, as I mentioned. Give you feel the little happy things that have happened over the years, but we've now been recognized for 17 years as a Ward 50 company. So there are about 3,000 property and casualty companies across the country, and we make it into the top 50 every year. So we go through a series of screening, safety, security, your ability to keep doing what you're doing. We have an AM Best rating of A, which we're very proud of, and we operate this competitive and residual market and state and federal risk. So there was a market collapse. There's no longer a market collapse. We really like competitors in our state. We want a healthy state environment, and I'll show you in a minute kind of how that all worked out, because the carriers had all left. And instead of having those rates going up by 260%, the rates have come down by 60%. So we charge 60% less for the business than when we started. Again, I work with an incredible group of teammates. One of them here, my partner today, Angela McGee, she'll talk to you in a minute, but we have just an incredible team, and we are very, very purpose-driven about everything we do. We are, we say, a model workers' comp provider and the champion of Louisiana. So what do I mean by that? We are the largest. You'll see we are dedicated solely to Louisiana, Louisiana employers, Louisiana workers. Most of the people who treat our employees are Louisiana physicians, Louisiana, so it really does create an ability to get to know the environment that you're in. I mentioned the rate decrease, and we've also been able to give back some of the premiums that our 20,000 policyholders have given us. In fact, at current standing, we've given back over $1 billion. So that money, when you have excess profit, if you will, you can look at that and you can release that back to the people who gave it to you in the first place. So we're very proud of that. That goes back to those Louisiana businesses, gets reinvested back in Louisiana's economy. We have paid over $2.6 billion to injured workers. And notice that I say injured workers. We don't say claimants. That's not okay in our business, because these are like, you want to treat them like you want to treat your other family members. And we also invest in Louisiana, so we've invested $518 million in mortgage securities, and that helps support the Louisiana housing market. And we've overseen the treatment and return to work of over 34,000 employees and serviced 186,000 work-related injuries. So here, do we have a good market? And I would say we absolutely have a good market. This is a 3-year snapshot, again, where there were no carriers in. There are a lot of carriers in. It's a really great, healthy, competitive market. We work hard at being competitive as well. So it's nobody that takes an easy bat or a bunt or anything like that. It goes every day, but it's really been a terrific thing. So I wanted to show you too, because I know some of you are from different states, and I don't know if you can read these states down at the bottom, but it goes from Pennsylvania over to Washington to the far right, and then the dark green is Louisiana LWCC. But what you have here is sort of a rating of funds. So I mentioned AM Best, and AM Best rates your funds, and A is the highest rating that you can get for a single state, single line carrier. Some of the funds in this group aren't trying to be rated. They're very, very different. So if you look over to the far right, Ohio, North Dakota, and Washington, those are monopolistic state funds. That's not a competitive environment. That state fund takes care of everyone. And they have 100% of the market accordingly. So you can see the ratings, but you can also see the percent of the market that each of your state funds has. So you'll see Maine over here at, close to 70%, now 65%. So they write a big portion of the market. Louisiana, LWCC is more at 30% of the market. So again, we try to balance that out. We don't want to get too big, but we need to be big enough to have critical mass and to do a good job and to do all the things that we need to do. But that's just kind of a look across the pond there to kind of see what everybody's doing. At this point, I'll turn it over to Angela McGee. She is going to take a deeper dive into Louisiana, but I'm happy to answer any questions if you have any before I do that.
Why don't we wait until after Angela speaks, and they can ask both of you questions. Go ahead.
You know what? I've got a couple more slides.
Angela, you're the underwriting and chief actuary.
Yep. You know, I didn't show you. I'll do this really quickly. Angela, like, Kristen, you just quit. But this is a purpose-driven business. Insurance is a primary purpose-driven industry, and workers' comp is, I believe, the biggest purpose, because we're taking care of people. And our mission is to elevate Louisiana and celebrate it. So we've got a movement, Louisiana Loyal, which is, if you're in Louisiana, hopefully you'll be seeing and hearing more about that. I'm not going to play the video here. It'll take just a minute, but there's a lot of activities that are going on to support that. And finally, here's our destination statement, just looking out a few years. So, you know, this is where we've been. We showed you that, but where are we going? And if you were to take a look at that, you could see that we're very proud to partner with all of our agents. We're about giving compassionate care to workers, and we want to make sure we're giving unique benefits to our policyholders, again, back in form of dividends, in forms of safety. But ultimately, we want Louisiana to be a great place to live and work, and we're doing our part, and we're going to work hard at that, and we're going to keep growing incrementally but carefully. So that's the economy is going to be elevated, and our payroll will get back to 10% of the overall state payroll, and we'll move our market share up to about 32%. So that, I think, is pretty close to it. There's a strategy map, and now we will move to Angela.
Thank you.
I think you have to turn yours off before I can.
Angela, if you will, get a little closer to the mic. Thank you.
Angela McGee.
There it goes.
I'm the Chief Actuary and the SVP over underwriting for LWCC. I've been in the industry about 25 years, so have a little bit of experience pricing. We're clicking through too fast. So I'm going to take you back just a little bit too. First, just covering some basics of workers' compensation and what it covers. So it's designed to provide benefits to workers who are injured on the job. Sometimes those injuries are clearly tied to the work that a person is doing. For example, if somebody falls off a ladder while they're working on a roof, that was obviously in the course and scope of their job and would naturally be considered a workers' compensation claim. And that would be covered under the traumatic injury portion of workers' compensation. But workers' comp also has an occupational disease component. So the one that you might be most familiar with is asbestosis, right? Before we realized that asbestos was as harmful as it is, this was a disease that some workers contracted while they were working with it. That would be covered under occupational disease portion of workers' compensation. But there's some requirements for it to qualify. It has to be due to causes and conditions that are characteristic and peculiar to the worker's trade. And it also has to result from those conditions present in the employment and not from other conditions to which the employee might be exposed. So you might think about, for example, the flu, right? So if someone is working in a doctor's office and a patient comes in and they have the flu, they might get the flu from that person, but we're all exposed to it, and it's all in everywhere we go. So it's not really peculiar to that person's trade because they're exposed to it elsewhere, not just in their occupational work. So how are presumptions different from workers' compensation? There are about 30 states, maybe a little more, that have presumptions for workers' compensation for certain occupations. So what the presumption does is take the burden of proof out of the employee's hands, and it puts it on the employer or the insurance company's hands to deny the claim. So for an injury to qualify for occupational disease, the employee has to prove that that disease was caused by the exposure. The presumption takes that completely out of the picture, and that disease is assumed to be caused by the work that the employee was doing. For occupational disease, disability is generally required, meaning that they can't work, right? So for a presumption, disability might be required, or like in Louisiana, disability is not required. Occupational disease is generally applicable to all employees who are covered under the Workers' Compensation Act. Presumptions are generally only applicable to employees who are in a certain occupation. And occupational disease has this characteristic of and peculiar to the trade that we talked about. A presumption has none of that. It doesn't have to have any kind of direct cause tied to their occupation. So the presumption, right, we want to think about, like, what's the problem with that? Well, workers' comp is based on causation. The whole point of workers' comp is to tie it back to what they were doing in the workplace. So the presumption actually contradicts the whole basis of workers' comp because it's assuming that it was tied to their work. This injury is tied to their work. So generally what happens with a presumption is it takes benefits or injuries that would have been treated under their general health care, and it shifts it over to workers' compensation. So what's wrong with that? Well, Kristen mentioned workers' comp rates have to be actuarially sound. So what that means is that you can't have any kind of subsidization across different types of occupations. So every occupation has a certain rate in each of your states, including Louisiana, and those rates have to be actuarially sound, which means it has to be tied back to the expected costs for that particular occupation. So we can't subsidize across industries. So as businesses increase benefits or employees are eligible for higher benefits, they end up with higher rates because it costs more. So the types of presumptions vary a little bit, as do the groups that are eligible for presumptions, but they're generally applicable to first responders. That's the most common area where we see presumptions, in particular firefighters. So they may cover a variety of diseases. Cancer and heart and lung are probably the most common, but we also see things like PTSD and even COVID-19, and Tim will talk a little more about that. So in Louisiana, just like work comp has evolved, the presumptions for firefighters have evolved significantly since work comp started. So back in 1914, when work comp was created, cancer was covered under occupational disease. So that would have been for anybody, including firefighters. Ultimately, in 1968, Louisiana opted to create a heart and lung presumption. So any heart attack or lung issue that a firefighter had would be presumed to have been caused in the workplace and therefore treated under workers' compensation rather than general health care. Cancer was later added. The cancer had to be disabling, so the worker had to be unable to work to qualify for the presumption, and it was limited to only a handful of different types of cancers that had been shown through research to be significantly tied to firefighter exposures. And it was applicable during the time the employee was working in the fire service and up to 5 years post leaving the service. About 9 years later, more cancers were added to the presumption. In 2006, a new presumption came in where hearing loss was covered. In 2017, we had a significant change. So in 2017, the disabling requirement was removed. And essentially every type of cancer was incorporated into the presumption, including things like prostate cancer that are generally more common in retired men, right, of that age, where the presumption applies post leaving the service. But the disabling piece was actually the more significant part, because now things like skin cancer, including things that you might just go into the dermatologist and have it removed, that's all work comp now. In 2019, PTSD benefits were added. In 2020, indemnity benefits for hearing loss claims were added. And then in 2022, we actually just went through some significant legislation where LWCC was able to help educate some of the stakeholders as this bill was being written and passed, where the cancer presumption was increased from 5 years after the firefighter leaves the service up to 10 years after they leave the service. So as long as they have 10 years of work with the service, they're covered during the time they're working and 10 years after they leave. So one of the significant changes there that offset the additional costs that are obviously going to be incurred as a result of more cancer claims being pulled into the work comp system is there was a reduction in the medical costs. So Louisiana has a very old medical fee schedule. So many of you are from states where your work comp fee schedule is likely tied to Medicare. So a lot of states may say, okay, all my work comp costs will be 150% of the Medicare schedule or 200% of the Medicare schedule. In Louisiana, our med fee schedule is actually 90% of whatever the provider charges for outpatient. So for all outpatient claims, I know you've all seen your EOB from your insurance company. You see the very high number, and then you see the reduction that for the insurance negotiated costs. Whatever that top number is, we pay 90% of that in Louisiana. So the medical costs in Louisiana are very, very significant, and they average about double what general health care pays. So it's huge when you add benefits like this to work comp. There has to be an offset, and that's what was done here. And so they opted to charge for any medical costs. We would now pay 150% of Medicare. So that offsets some of those additional claims costs that are coming into the system. So these cancer presumptions, just like state funds, you've seen one, and these cancer presumptions are very, very different across states. So I was just going to walk through some of the different characteristics. On the left in the light green is a less generous provision in the presumption, and on the right is the more generous, meaning they get more generous benefits. So this starts from just having a presumption. So in many states, there's actually about 10 states where there is a presumption for cancer in firefighters, but it's actually removed from work comp and covered under some kind of different provision. So they have a special policy or provision that provides benefits for those. So in Louisiana, we started as being an occupational disease, and we are now obviously presumed to be covered under work comp or caused by the workplace. In some states, there's also a service eligibility requirement. So the firefighter may have to work a certain amount of time before they would be covered under the presumption. Some states actually have no minimum. They're covered day one by the presumption. Louisiana, we're on the 10-year side, so they have to work 10 years to be eligible for the presumption. There's a presumption application period. There are a handful of states that only provide that presumption while the firefighter is employed, meaning once they leave the service, the presumption no longer applies. And there's actually one state that provides this presumption for life. So Louisiana, we started at up to 5 years post leaving the service, and we're now 10 years post leaving the service. It also varies depending on the type of cancer. So some states have the low end of 4 different cancers that are covered, all the way up to all types of cancers. And Louisiana has obviously been moved all the way up to the all types of cancers now. The ability to rebut. So in Louisiana, if the firefighter has cancer, there is really no way for the employer or the insurance company to rebut or argue against that to deny the claim. Some states have the ability to do this through tobacco use. If the firefighter used tobacco or there's some kind of family history, the employer may be able to rebut that claim. And then the disability requirement that we've talked about. So Louisiana started as being unable to work. We now have no disability requirement. There are also a handful of states where there's really only coverage if the firefighter passes away from the cancer.
Angela, can you summarize maybe?
Yep, this is it. I'm
Okay,
done. So it's the last one, and just giving you an idea of the average cost across states. So that's it.
Yeah, listen, thank you for your presentation. I just have 2 quick questions, and
Sure.
the chairman and I can ask them. One is, we don't cover mental health unless there's an accident first. Is that how you do it here?
It depends on the state. So that actually,
I know it
there's.
does. I just want, how do you guys do it?
I'm sorry?
Yeah, I know it depends on the
Yep.
state. How does
So
Louisiana-
that's like PTSD here. So in Louisiana for firefighters, we have a PTSD presumption, which would mean if they're on the scene of an accident and they suffer from some kind of mental issue afterwards, then that would be covered automatically for first responders.
So, but do you separate post-traumatic stress from any other mental health condition that they think was brought on by that? I mean, in Ohio, you have to have an accident, an injury first.
Yes.
Before. Do you do that also or not?
Here it's presumed. So for firefighters, it's presumed to have been caused by that accident. If it was another occupation, then I think you would have to tie it back to that particular incident in order for them to have some kind of coverage for
And the
that.
second question, we just passed in Ohio last couple of years a cancer exemption, but we did put in a 10-year, if the person's been smoking their whole life, we put in a 10-year exclusion that they had to quit smoking for the last 10 years
Right.
before we pay on lung cancer. How do you guys handle that?
There's none of that here. Even if they're smoking, they are eligible. It doesn't matter what the firefighter has done during their employment or pre-employment. It's covered here.
Okay, thank you. Any other questions? Anybody? I think, but for either one of them? Listen, thank you.
Sure.
Okay, our last speaker is Tim Tucker, from Washington Affairs, Executive, External, and Governmental Affairs, the National Council on Compensation Insurance. It's all yours, and he's going to bring us up to date on legislative and regulatory trends. It's all
Great.
yours.
Thank you, Senator Hackett, members of the committee. Great to be before you today. I'm going to go through some of these issues that you've all been working on in the states in somewhat of a rapid-fire fashion in the interest of time. The good news is that all the things I'm going to go through rapidly are available at ncci.com through the numerous resources we have. So this year's been somewhat typical in the volume of legislation and regulations you all have been working on in your respective states. We've seen about 800 bills be considered countrywide, 450 in NCCI states. About 100 of those were actually enacted, and of course 120 of those dealt with COVID-19 and workers' compensation. So briefly, I'll touch upon COVID-19 and comp. Mental injuries, we'll touch upon a little bit about what you referring to, Senator Hackett. Marijuana legalization, single-payer health insurance initiatives and their impact on workers' compensation and worker classification. So what we've seen, obviously, with the onset of the pandemic back in 2020, we saw states take various approaches to the presumption, similar to that which we've seen for firefighters and other first responders previously for COVID-19. In this past year, several states have extended the deadline for those presumptions and extended them into the future. Others have expanded the presumptions. Initially, in some states, they were solely for first responders. They've been expanded in some cases to other occupations as well. There's been some activity around that. And of course, new presumptions have been considered. Some states who did not act at the onset of the pandemic have looked back, and some have actually retroactively enacted legislation to cover injuries caused by exposure to the COVID-19 virus. So, and then of course, we talked a little bit about infectious diseases. Some states have taken a very broad approach and actually have gone and amended the occupational disease provisions of their workers' compensation acts to include various infectious diseases as compensable under their state workers' compensation statutes. Something new this year, and not surprisingly, states have taken a look at the impact of the COVID-19 vaccines and potential compensable scenarios for workers. Several bills were introduced that established presumptions for adverse impacts to the vaccination. There have been a number of bills that specify that injuries from the vaccine are compensable under work comp laws, and 2 states actually enacted legislation that creates a private right of action against the employer if they mandate vaccinations for their workforce. Mental injuries, we've seen uptick in this area as far as legislative and regulatory proposals. 60 bills, 45 of those relate to PTSD. A handful of states have actually enacted those proposals. And just briefly going, state activity related to marijuana legalization. As you all know, the impacts of marijuana legalization reaches a lot of different areas, and including the workplace. Some states this year, Rhode Island enacted legislation that approved the use of recreational marijuana for recreational purposes. 2 states last week, by ballot initiative, Maryland and Missouri, the voters passed ballot initiatives to make marijuana legal for recreational purposes. And then, of course, the issue that some state courts have been grappling with are the reimbursement for by carriers of marijuana for injured employees. So I think that's a trend we'll see more. The courts are working those through now, both at the state and federal level. Certainly more to come. The states, comparatively, on the marijuana reform issue are far ahead of the federal government. For years, there's been different proposals to legalize or otherwise address the treatment of marijuana under federal law. The real tension in Congress now is really the scope of those reforms. It is one of those odd bipartisan, bicameral issues that enjoys support. The devil happens to be in the details, whether to go a comprehensive approach such as the Cannabis Administration and Opportunity Act that Senators Schumer and Wyden and Booker put forward earlier this year, which has a host of provisions from expungement of criminal records to the creation of a regulatory framework to a taxation mechanism. So just this week, actually, the House Oversight Committee had a hearing on marijuana reform at the federal level. There does appear to be some bipartisan support for doing something, perhaps even in the upcoming lame duck. The principles that were laid out in a joint memo released over the weekend by both the House and House Republicans and Democrats put a framework together that addresses those issues I just mentioned: expungement, taxation, and a regulatory framework. There is a chance there could be a narrow reform, such as the Safe and Fair Enforcement Banking Act, and that creates a safe harbor for banks, insurers, and others who are working with legitimate cannabis-related enterprises. And so I mentioned the hearing this week, so we'll see if there's enough time and momentum to get something across the finish line before the 118th Congress comes in January. Let me move next, and I'll just be very brief on the single payer. Obviously, states have looked at this in varying degrees for decades now. The one stumbling point that always seems to come up is how to treat workers' compensation, medical costs, and whatnot. States generally have kicked the can down the road and created a board or a commission within the proposed framework to deal with workers' compensation. So it really does present a challenge when you're looking at these universal single-payer systems. I will also note that for a number of years, Medicare for All has been introduced in Congress, which would create a single-payer universal plan. And the provision within the Medicare for All Act does require carriers, workers' compensation carriers, to reimburse the Medicare for All program for services rendered to injured workers. So something that needs to be considered when policymakers are looking at moving towards a single-payer healthcare system. And then, of course, worker classification continues to be a significant issue. States have taken various approaches. I know several states have carved out transportation network companies or other gig-type employments and treated them different than other independent contractors. And some states have created a framework that would provide certain benefits and services to those gig workers. At the federal level, the Biden administration has proposed regulations that would really create a more stringent framework for the classification of workers, making it more difficult to classify workers as independent contractors. That is open for comment now. It really looks a lot like, if you're familiar with Assembly Bill 5 in California from a number of years ago, which created a framework for employee classification. Looks a lot like that ABC test in California. So we'll see what happens. I can expect that there'll be legal challenges to the Biden administration independent contractor rule. So one thing I wanted to follow up from our July meeting, we presented to you our state of the line with my colleague Jeff Ettinger. As he indicated at that time, we were just beginning our annual rate filing season. We are about 3/4 of way through that. You can look to see how your state compares to others. I will tell you, with the exception of Hawaii, in all NCCI jurisdictions, we have filed rate decreases so far this year. So we have about 32 of 38 states filed, and those, with the exception of Hawaii, indicate decreases. And then, enough looking through the rearview mirror, I wanted to put a few things on your radar for the coming year. NCCI will continue to examine the impact of COVID-19, both in terms of the impact of long COVID, as well as the existing trend of claims. Earlier this week, NCCI, as well as some of our independent bureau partners, 45 jurisdictions in all, released a report on the claims activity around COVID-19. A couple of numbers that stand out, I think, to all of you. There's been $1.1 billion in COVID claims paid to date. That represents 117,000 claims with an average claim of just below $10,000. So you can see that there's been quite a bit of activity around COVID-19 claims that has impacted the industry. Another thing to keep an eye on is obviously trends in claim frequency and severity. While we've seen some severity tick up a little bit, largely has been offset by the continued decade or more long trend down in in frequency. And then lastly, and not surprisingly, something that we've always kept our finger on is the impact of medical costs on workers' compensation, both in terms of course, inflation, but also utilization. So those are some things that I think we'll be looking at and determining how they impact workers' compensation going forward. So I appreciate your time. I apologize for the brevity, but again, all the topics I mentioned are available on ncci.com.
Thank you. Thank you for your testimony. Any questions from the committee? Looks like none. Is there any other business today to be brought before the committee? If not, we stand adjourned. Our next session is I'll look at it real quick, is the Life Insurance and Financial Planning Committee run by Representative Carl Anderson from South Carolina. We're adjourned. Thank you.